Welcome to the Neurology Live Mind Moments podcast. Tune in to hear leaders in neurology sound off on topics that impact your clinical practice. I'm your host, Marco Meglio, editor with Neurology Live. In this episode, we sat down with Dr. Sneha Mantri, Chief Medical Officer at the Parkinson's Foundation, who spoke on how mood and behavioral symptoms shape the experience of patients with Parkinson's disease. Mantri, a practicing movement disorder specialist, spoke on how depression and anxiety evolve with cognitive change and why they remain key drivers of quality of life. She also reviewed commonly used screening tools, as well as highlighted the role the Parkinson's Foundation has in supporting clinicians and patients with PD. Furthermore, Mantri concluded with the ongoing challenges of these issues, such as cultural barriers to mental health care, access limitations, and the continued need for true mental health parity in PD management. Let's dive in.
Mood symptoms and behavioral symptoms are, as you said, one of the biggest drivers of quality of life for a lot of people with Parkinson's disease. And when you look longitudinally, some of these symptoms start even before the development of the more classic motor symptoms that sort of get people's attention. Particularly depressive symptoms, anxiety symptoms often will predate the development of any physical symptoms of Parkinson's disease. It's thought to be related to changes in dopamine transmission in the brain and sort of the differential effects of dopamine in different kind of sub regions of the striatum, which leads to these new symptoms. So particularly patients or people who have not previously experienced depression or anxiety, but then in midlife or as they sort of move into their 50s and 60s, if they start to develop new depression, new anxiety, that should be a little bit of a, I won't quite call it a red flag because there are a lot of things that can cause depression and anxiety, but it should sort of raise awareness in the clinician that there may be something deeper going on than sort of merely, I hate to say merely depression or anxiety, but can be an indicator of a more comprehensive neurodegenerative process like Parkinsonism. Um, and I would say that, as the disease progresses, then um, anxiety and depression start to become often more and more prominent and can be really the biggest drivers of quality of life for patients. Part of that may be related to, adjustment to this new diagnosis and sort of more of an adjustment disorder diagnosis rather than a major depressive or a generalized anxiety disorder diagnosis. But even beyond the sort of acute, adjustment phase, a lot of people have real struggles with depression in particular. It's often underrecognized in the clinical setting, and can, it's quite amenable to treatment, and so it's really doing our patients, a disservice if we're not aware of the impact of mood, aware of the impact of anxiety throughout all stages of the disease. And with regard to behavioral issues specifically, clinically, I often see that more in the later stages of Parkinson's or Parkinsonism, perhaps when people have started to develop some degree of cognitive impairment, and they sort of don't have quite as much frontal like executive function to sort of have insight into what's going on or into different symptomatology, and patients can start to develop pretty significant sometimes behavioral concerns. Often that's brought up by the care partner more so than the patient because of that change in insight. But it is something that I think as clinicians we need to be aware of, that this is a potential issue for people, and provide sort of anticipatory guidance and counseling to our patients even earlier in the disease before these issues arise, to help patients and families kind of think ahead about what comes next.
Yeah, I mean, there's certainly some patients and families who kind of just assume that this is how things work and that there's not much that we can be doing about it. But there are things that we can be doing to help patients and help their families out and things of that sorts. Dr. Mantri, I'm also curious from your perspective, we've seen not just inside neurology, but from a general medical healthcare perspective, obviously things like depression, mental health, and some of these social aspects, psychosocial aspects have been brought to light a little bit more over the last decade or so. And like I said, not just in neurology. So, talk a little bit about how the conversation around treating mood and behavior issues in Parkinson's has evolved and changed over time.
Yeah, that's a fantastic question because you're right. I think generally in our society, and in particular, in the types of like neurodegenerative disorders or neuropsychiatric conditions, I think there's a lot less stigma now than there was perhaps 10 years ago or like when I started my career. Not to say that, I mean, there still is more stigma than we like around mental health diagnoses, but I think people are more open about the impact that Parkinson's disease can have, again, not only on their physical symptoms, but really on their whole, life and their personality and their mood. And so I think, between the combination of generally in society, people are more open about, I'm seeking mental health care for X or openness about going to therapy, like 10 or 15 years ago, that was not, I think, talked about as much as it is now. So that I think has really helped patients sort of come forward and feel comfortable bringing it up with their clinicians. I think on the flip side too, there's been a lot better education of clinicians about the impact of these symptoms on people's quality of life. And so we're doing, I think, also a better job about proactively asking and addressing these concerns. And many clinics now, at least in sort of academic settings, perhaps maybe a little bit more so than in the community, unfortunately, but even so have integrated psychiatric care or social workers or counselors, therapists, people that we can sort of lean on to help deliver the best care to our patients sort of in an integrated or in a comprehensive way, so that it's not quite so fragmented, I think, as it used to be, where a lot of burden was placed on patients and families to seek out a therapist or a psychiatrist or a counselor. Now a lot of that is recognized by the healthcare system and the importance of integrating that into, primary care offices or into neurology offices, so that we have a lot more fluid conversation, about these issues. And it also, I think, certainly delivers better care to our patients. I think it also helps as clinicians, if we can, talk directly to the social worker or the psychiatrist and we know that person and they're kind of part of our care team, it really helps, I think, with clinician, burnout or moral injury when we're trying to figure out, who can we refer this patient to who understands Parkinson's disease. If I have, a list of people kind of that are integrated into my practice or into my clinic, it makes it a lot easier on me as the clinician to feel comfortable, sort of bringing that up with my patients.
Yeah, it seems like neurology has become a little bit less siloed over the years, and that we've kind of been a little bit more integrative with some of the other departments and some of the other specialists and things of that sorts, working a little bit closer with these people. Unfortunately, obviously, with Parkinson's, we haven't seen as much palliative care kind of come to fruition a little bit more. Obviously, there's a lot of funding issues with some of those things, but it's at least greater importance that we've seen more on some of these psychosocial aspects. Dr. Mantri, we've kind of talked about the fact that there are things that we can do for patients and that we can help them out, and that, when they are feeling these sorts of things, that we do have options. So, talk a little bit about the screening tools or even the clinical assessments that you find most useful for identifying some of these mood issues, as well as also how can we potentially act on some of these mood and behavior disturbances that we see.
Yeah, fantastic question. Because there's so many different sort of screening tools out there, and it can almost feel, a little overwhelming, like, which one should I pick that's the most useful or the highest yield for this patient population? A lot of studies of depression in Parkinson's disease will use something like the Geriatric Depression Scale as the screening metric. For instance, some of the largest observational studies of Parkinson's disease, the Parkinson's Progression Markers Initiative, the Parkinson's Outcomes Project, both use the GDS as the sort of the screener for patients. It's convenient in a lot of ways because it's quite simple for patients to fill out. It's yes, no questions, and then you sum up the score at the end, and you get, essentially a binary of whether or not this person may be depressed or less likely to be depressed. I guess I should say also, of course, any screening tool is just a screener. It doesn't make the diagnosis. It just can help highlight or triage which patients may need a little bit more kind of investigation around, say, depression or anxiety. For anxiety, I often see the GAD-7, the generalized anxiety disorder 7 question, sort of, again, patient reported questionnaire, that's most often used. In my own clinic, we tend to favor the PHQ-2, the patient health questionnaire, partly just because of reasons of logistics. It's a 2 question sort of initial screen. And then if the patient screens positive on those two, it sort of flows forward into a more detailed 9 question assessment. So, particularly if patients are screening negative, you ask those 2 questions and then, you move on. If they screen positive, with any of these tools, you're having a more detailed or more in-depth conversation about, what's the reason for their mood symptoms, or, what else may be going on in their life that could be contributing to, the mood issues. Um, yeah, and I would say that, one of the things that we are also trying to pilot in both in our Parkinson's clinic and in our ALS clinic, actually, is something called the HOPE questionnaire, which was developed by a person with ALS, actually, who was, I think, a little bit understandably frustrated with the conversations he was having with his clinicians about decline and, everything's getting worse all the time and so on. And he had this sort of brilliant idea to think about hope as a positive force in the clinical encounter. So, not with every patient, but for patients who are, taking part in this kind of pilot program, if you will. We're starting to ask about hope and sort of positive change, things like adaptability or creativity or gratitude, or this whole concept of post-traumatic growth, even in the face of a difficult illness like Parkinson's, ALS. There are moments of hope and joy, and so I bring that up just because that is almost, in some ways, the flip side of depression or anxiety. And so you can see that if somebody is sort of scoring poorly on some of these hope questions, that could also be an indicator that this person is depressed, and they're not sort of able, if you will, to see some of those moments of happiness in their life, partly because the depression sort of colors the way that you see everything. So it's just, again, this is like very early stages, and but I think it is a neat way of thinking about mood disorders. Again, not just in the negative, but also like what could be the positive, or what could be, a growth area for patients, even in the midst of, all of the other changes that Parkinson's, say, can bring to them.
We're going to take a quick break from our conversation with Dr. Mantri to keep you up to date on the latest developments in neurology. Welcome to the Neurology News Minute. Here's what you may have missed since our last episode. First, on November 4th at the 2025 CTAD conference, new data from the EVOKE and EVOKE Plus trials show that semaglutide, or Ozempic, a GLP-1 agonist, did not significantly slow Alzheimer's disease progression despite biomarker improvements. Based on the negative data, Novo Nordisk decided to discontinue its 1-year extension period of the trials. Next up, days later at the 2025 AES annual meeting, new phase 1/2 data from the Polaris program showed that ETX-101, a one-time investigational gene therapy, was safe and led to dose-dependent effects on seizure outcomes in patients with Dravet syndrome. These findings, along with positive data in neurodevelopmental outcomes and cognition, further supported the drug's continued development. And finally, on December 9th, the FDA accepted Tri-Pharma's new drug application for TRN-257, a low-sodium oxybate, as a treatment of cataplexy or excessive daytime sleepiness in patients with narcolepsy as well as those with idiopathic hypersomnia. The agency has scheduled a PDUFA date of June 20th, 2026 for the once-nightly therapy. For more information about these stories, head to neurologylive.com, or you can check out the corresponding link in the show notes. And now, back to our conversation with Dr. Mantri.
Dr. Mantri, I'm also curious, obviously, from the Parkinson's Foundation perspective, there's a lot of different types of initiatives and things that you guys are working on. So how, and not just yourselves, but how is the community trying to change the conversation around treating mood and behavior in Parkinson's? What sort of initiatives, what sort of conversations are being had? And also, what does the kind of future outlook look like for treating these kind of secondary symptoms?
Yeah, absolutely. I mean, I think there's a lot of different avenues that we at the foundation and just generally, people with Parkinson's and their care partners and clinicians caring for them are exploring. One is, for instance, this HOPE initiative or HOPE scale to try and sort of flip the conversation a little bit. I would say the other area that the foundation is really involved in is things like the PD Health at Home series. This is an online webinar series that runs Monday, Wednesday, Friday throughout the year. Started during the pandemic, when everything had to go online very quickly, but it's really continued because it's gotten such great response from the community. And one component of that on Mondays is something called Mindfulness Mondays that sort of allows patients and care partners and really anyone tuning in to learn a little bit about some non-pharmacological approaches to managing depression or anxiety, mindfulness being one of them. There's also Wellness Wednesdays that sort of take a more, I think, global approach to wellness, talking about things like diet and nutrition and exercise and all of these other components that play into our quality of life. And there's really good evidence that exercise in particular can be beneficial for depressive symptoms, partly through again the release of some of these growth factors and dopamine and so on in the exercise itself or during the exercise itself. And then there's also Fitness Fridays, which is more kind of very much geared towards exercise. It's like exercise classes online for folks with Parkinson's. So I'd say that's probably one of the biggest areas that the foundation has been sort of leading over the years. The foundation also leads a Parkinson's Disease Awareness Month every April, which is sort of focused on, different topics. But one of the areas that, I think we really kind of emphasize every year is the concept of stigma and the way that stigma can sort of limit people from sharing their stories, can make people feel more isolated and so on. And so giving patients and families avenues to share what they're going through, to connect with others. Those are all really great ways to help with mood symptoms and with behavior symptoms in Parkinson's disease. And then lastly, the foundation is really involved in a lot of educational programs for clinicians, both, professional webinar series around different topics in Parkinson's, including non-motor symptoms, as well as live programming through things like the Parkinson's Foundation Team Training Program, which brings together clinicians of all stripes to talk about, complex issues in Parkinson's disease. And there's, we often do programming in conjunction with some of the other big neurology meetings, like the American Academy of Neurology meeting or the Movement Disorder Society meeting. We'll often have a component where we can kind of talk about some of these issues and the ways that the foundation can help clinicians to meet the needs of their patients as well as possible.
Wow, very awesome. A lot of different types of things that you guys are offering, not just to the patient community, but the clinician community themselves. So really, really awesome to say the least. Dr. Mantri, I have one last question for you. We've talked about a lot of the great work that's been done, to kind of help mood and behavior issues in patients with Parkinson's, but In your opinion, what are some of the more troubling unanswered questions that we still have about some of these symptoms? Where are some of the issues that still kind of arise, and what are some of the challenges or roadblocks that we still have in front of us?
Oh, yeah, fantastic questions. There are so many potential things I could say in response. I mean, I would say that, for me, often the biggest challenge is still around just opening the door to that conversation. As I alluded to, I think stigma and openness has gotten a lot better over the last several years, but I think we still have a long way to go, particularly for certain patient populations. Parkinson's disease and depression and anxiety affect all people of all races and ethnicities, but because this is so culturally mediated, sometimes there are particular, cultural factors that can inhibit people from being, open about this with their families or with their clinical team. So I think that's one piece of it is sort of doing a better job of outreach to particular cultural communities and sort of culturally aware programming around mood symptoms or behavior symptoms. And then the other thing, more on a sort of system level, is unfortunately we still don't have real mental health parity in this country, which I think really limits the availability of, for instance, psychiatrists or therapists or counselors to meet the needs of patients, just because of frankly, it comes down to like the business angle of it. And so unfortunately, when insurance companies, for instance, don't cover therapy to the same degree that they cover medical visits, it makes it really challenging for the counselors to, maintain their business model, but also for patients who are then often being asked to sort of pay out of pocket in a, for a condition that's, strongly related to their Parkinson's disease, but is not recognized in the same way. So I think continuing to advocate for better mental health parity and better availability of some of these services will go a long way towards, making it accessible for all people with Parkinson's disease.
Thanks for listening to this episode of the Neurology Live Mind Moments podcast. To support the show, be sure to rate, review, and subscribe wherever you listen to podcasts. And as always, for more neurology news and expert-driven content, visit neurologylive.com.